Greetings. Let us learn about chronic pancreatitis. And when it comes to chronic pancreatitis, it can lead to exocrine pancreatic insufficiency. And in order to understand that, we should start learning about the basics of digestion. So, I'm grateful to my mentor, Dr. John Stroline, Mr. Charles Butt, for their philanthropy support, Miss Angela Deal, my institution, and all my mentors. Please read this notice. So let us look at what happens when somebody eats a Big Mac. And if you look at it, it has three components. The bun is carbohydrate, the protein patty, and then cheese, that is fat. So let us use this as an example. Say, for example, if you eat a Big Mac, what all is involved in digesting the carbohydrate, protein, and fat? So let us start with carbohydrate. And the digestion of carbohydrate starts in the mouth from the salivary secretions, salivary amylase that actually starts digesting the starch in the bun. And salivary amylase breaks down the starch into oligosaccharides and disaccharides. And as the food goes down, nothing happens in the stomach. And then the next step in the digestion happens from the pancreatic amylase. And what pancreatic amylase does is it acts on the oligosaccharides and disaccharides, products of salivary amylase action, and converts them into disaccharides from oligosaccharides and from disaccharides to monosaccharides. And these are absorbed by the intestinal villi in the jejunum and in the small intestine. Say, for example, because of pancreatic insufficiency or exocrine pancreatic insufficiency, and there is not much of pancreatic amylase output that leads to maldigestion of carbohydrates. So when the carbohydrates, oligosaccharides and disaccharides, they don't get absorbed, they don't get they're not absorbed. The oligosaccharides and disaccharides go down the stream, and then the bacteria ferment, produce a lot of gas, and that results in bloating, flatulence, diarrhea, and with the loss of energy in the carbohydrate, one could also lose weight. So whenever you have bloating and gas, you should think about, is there a maldigestion and malabsorption of carbohydrates? So now let us move to the protein patty in the Big Mac. So the protein digestion starts in the stomach, and the HCl, that is hydrochloric acid, denatures the protein, resulting in denatured protein. And then the stomach also secretes pepsin, which starts breaking down the denatured protein into polypeptide chains. The next step of protein digestion happens in the duodenum from pancreatic proteases. And the pancreatic proteases consists of the main enzyme is trypsin, is secreted as trypsinogen, inactive form from the pancreas uh, by the effect of enterokinase. Trypsinogen becomes trypsin, and then the trypsin starts activating every other enzyme that is secreted in an inactive form. So we see trypsin, chymotrypsin, carboxypeptidase, and ribonuclease. In addition, there is elastase. So what do these pancreatic proteases or proteolytic enzymes do? They break down the polypeptide chains into smaller peptides and amino acids. And these in turn are absorbed by the small intestinal villi. So, say for example, the patient has chronic pancreatitis and there is exocrine pancreatic insufficiency, and there's not much of pancreatic proteases reaching the duodenum, then it results in maldigestion of the proteins. And this maldigestion of the protein results again to some type of bloating and gas, and they can have diarrhea, and they can also have weight loss and muscle wasting. So let us take a step here and learn a little more about the pancreatic proteases. We have two types of proteases, pancreatic proteases, trypsin, chymotrypsin, carboxypeptidase, and ribonuclease. These are labile. That means as they go down the stream, they're going to get destroyed. So you cannot measure them well in the stool. On the other hand, elastase is very stable. That means you could measure elastase level in the stool, and this is what we use in the setting of pancreatic insufficiency by measuring fecal elastase to figure out whether there is exocrine pancreatic insufficiency or dysfunction. Depending upon how severe the level is or loss of secretion is, we define it as exocrine pancreatic dysfunction if there is no steatorrhea, and insufficiency if there is steatorrhea and fat-soluble vitamin deficiency. So this is a very important concept you should keep in mind. And we will learn a lot more about how do you evaluate the different degrees of exocrine pancreatic dysfunction and insufficiency later on. Now let us move on from carbohydrates, proteins, to fats. In this case, cheese. And it is important to keep in mind that lipase is not just from the pancreas. There is lipase in the stomach as well, gastric lipase. And gastric lipase acts on the fat and converts them into triglycerides, diglycerides, and free fatty acids. And this gastric lipase may be upregulated in patients with chronic pancreatitis, so that the body has a way to still digest and absorb fat in a patient with pancreatic insufficiency. This is a compensatory mechanism that can work in patients with pancreatic insufficiency. So think about gastric lipase like salivary amylase and pancreatic amylase, gastric lipase and pancreatic lipase. So we heard about gastric lipase from lipids to triglycerides, diglycerides, and free fatty acids. And then once the chyme comes into the small bowel, the duodenum, the pancreatic lipase further breaks down the triglycerides, diglycerides, monoglycerides, and free fatty acids. So the pancreatic lipase basically cleaves off some more to create free fatty acids and monoglycerides. We also know that for fat digestion, we need bile, and the bile results in creating micelles, and those are helpful in the final absorption of the fat into the body through the jejunal lacteals as well as the capillaries and venules, depending upon whether there is uh, a medium chain triglycerides or not. So something to keep in mind. How about when there is pancreatic lipase level is low, secretion of pancreatic lipase into the duodenum is low in the setting of uh, chronic pancreatitis with pancreatic insufficiency. It results in maldigestion of fat. So what happens? The partially digested fat, the triglycerides, diglycerides, and free fatty acids that were partially digested by the gastric lipase, they escape down the gut and come out in the stool, resulting steatorrhea. Steatorrhea, the patient typically complains of foul-smelling stool that sticks to the toilet, and somebody needs to needs to do a lot of flushing of the toilet to get rid of that sticky stool. If the insufficiency is very severe, patients may report that they have seen oil lakes in the stool. In addition to that, patients can have bloating and gas as well as some diarrhea. They all lose weight with severe pancreatic insufficiency. And at the extreme, they may also have maldigestion and malabsorption of fat-soluble vitamins, vitamin A, vitamin D, vitamin E, and vitamin K. So we talked about the digestion of carbohydrate, protein, and fat. Carbohydrate digestion starts in the mouth from the salivary gland amylase and later in the pancreatic by the pancreatic amylase. When it comes to protein, digestion starts in the stomach with the help of hydrochloric acid and pepsin and later pancreatic proteases. When it comes to fat, digestion starts in the stomach with gastric lipase a little bit, but most of it is in the from the pancreas, the pancreatic lipase, along with the help of bile salts. And important to keep in mind that elastase, one of the pancreatic enzymes, is stable and it can be measured in the stool. And if the level is low in the stool, you diagnose pancreatic dysfunction. And if the level is low and there is also fat malabsorption and excessive loss of stool, excessive loss of fat in the stool or steatorrhea, then you diagnose exocrine pancreatic insufficiency. The difference between dysfunction and insufficiency is in insufficiency, patient will have steatorrhea and with or without fat-soluble vitamin deficiencies. In dysfunction, they have only low fecal elastase in the stool, but no steatorrhea. When you do 72-hour stool fat collection, their stool fat may be normal or borderline normal, that is less than 7%. Sometimes it may be a little bit higher. But if it is above 15%, then you know that it is pancreatic insufficiency. So you have to differentiate dysfunction versus insufficiency. In insufficiency, you replace pancreatic enzymes to treat the patient. For dysfunction, you monitor till they get into trouble. Thank you.